Um, Pathology outlines odontogenic tumors, odontogenic fibroma. Definition general, rare, benign, mesenchymal odontogenic tumor composed of mature fibrous tissue with variable amounts of inactive appearing odontogenic epithelium. So it is rare, but it is benign, occur in mesenchymal. It is mesenchymal tumor. If we'd like to transfer to malignant, it will be sarcoma. Composition of fibrous tissue, mature, and inactive epithelium. We can identify this tumor by the presence of calcifications and two common variants. It will be either intraosseous or central odontogenic fibroma, or extraosseous or intraosseous, which will be central, or extraosseous, which will be peripheral. Peripheral and centered in gingival tissue associated with tooth-bearing regions of jaws. Rare variants. It is rare tumor. Essential features: strands or nests of odontogenic epithelium. It will be appear on the slide as strands or nests of epithelium derived from odontogenic, with or without calcifications. Variable cellular fibrocollagenous stroma. Terminology: we will find many terms for this tumor, named either odontogenic fibroma, central odontogenic fibroma, peripheral odontogenic fibroma. Epidemiology: it occurs between 20 to 40 years. Peripheral fibroma more common than central. Peripheral, we mean extraosseous. Peripheral fibroma occurs twice time also often in females, so it is more common in females. Female rediculation, where occur location, sites, mandible and maxilla affected equally in mandible or maxilla, but peripheral more common in anterior ganglial region, while central more common in mandible. Posterior to first molar, most involving maxilla are anterior to first molar. So sites or location, mandible or maxilla affected equally. Peripheral fibroma occur in anterior gingiva, while central fibroma occur in posterior to first molar. Clinical feature: asymptomatic. If symptomatic, can present with swelling and pain. Diagnosis depend on clinical, radiologic, pathological correlation. Pathologic description can present as unilocular or multilocular radiolucency with distinct borders. Root resorption and displacement of teeth have been reported. 10% exhibit radio-opaque plaques that correlate with calcification. So this is radiology images. This is radiology images, IOPA, showing irregular radio-opaque masses, showing well-defined radiolucency. It is so clear there. Irregular radio, while the other slide multilocular radiolucency near 21, 22, 63, 24 and 25, as we will see here. It is so clear as shown in the arrows. And in back tooth, arrowhead will appear multilocular radiolucency arrowhead, while arrow show impacted teeth in the floor of maxillary sinus. So clear radiology description. Prognosis: peripheral highly recurrent, while central recurrence uncommon. Case report: 20-year-old boy with a slow growing asymptomatic. This is cases. It occur in young. This is 20-year boy, slow growing or retarded growth, asymptomatic, gingival mass distal to the mandibular right first molar, or asymptomatic firm sessile gingival mass, or central fibroma are dentigeral cysts in the maxilla, not in mandible, or fibroma of the posterior maxilla in an 18-year-old man. So treatment treated by excision, but at high recurrence. Central deteriorated by inoculation and cortage. Clinical image, as we will see. Clinical image, as we will have seen. It is so clear photograph showing 3 cm by 5 cm swelling extending from the left upper permanent canine to the second permanent premolar. And the slide so clear. Preoperative clinical presentation of the lesion so clear. Anterior to the gingiva, while the another posterior to the gingiva. Images. This is for surgical intervention on the cross specimen after surgery. This surgical picture. Surgical intervention of odontogenic fibroma after excision. Microscopic histologic description. It is so high slides, but not so bad. It consists of variably cellular collagenous tissue with scattered small inactive odontogenic epithelium and stranded cordis or nestis. So it is cellular fibers, either fibrin or collagen, with scattered inactive small epithelium in strandis or cordis or nestis. Calcification can be seen in association with epithelium and extent. When extent could consider classification as ossifying variant of odontogenic fibroma. So odontogenic fibroma, as we can see here, variable amount of inactive odontogenic epithelium distributed within dense fibrous tissue. We say that fibrocollagenous with scattered small inactive epithelium in nestis or solidus. We may also see calcifications. Extensive. When you want to see calcifications, we will consider about ossifying either extra or intra central calcification, central fibroma, extra osseous, peripheral fibroma. Rare variant is association, ossifying variant of odontogenic fibroma, epithelial islands intimately admixed with bone trabecula. Okay. As we have seen here. Ossifying variant of central odontogenic fibroma. Fibroosseous, as you see by the arrow. Fibroosseous. Interposed among avoid densely being tubercle calcification. While this is in C slide, this is named by immunohistochemistry. Stained by cytokeratins. Stain the epithelium. We will see the calcification so clearly. The central calcification shown on this arrow. So, trabecula islands, epithelial islands admixed with bone trabecula. We'll repeat that. Bone trabecula with epithelial gland, epithelial cells, also see in arrow. Epithelial cells in bone trabecula. Granular cell odontogenic fibroma. The first was ossifying variant, the secret granular cell, characterized by granular cell appearance within the epithelial stromal granular cells. Not appear in these slides. Not appear, but you will see it. Central fibroma with amyloid-like protein deposition. Characteristic of central odontogenic fibroma with ovoid or globular acellular hyalinized structures. We will see ovoid or globular. The most important is acellular hyalinized structure and possible areas of periepithelial amyloid deposition. Coughing, we will see amyloid deposition. Deposit is positive for Congo red. Congo red is a special stain for amyloid, demonstrated green by refrangens under polarized light examination. Positive immunohistochemical reaction by employing antibody. In immunohistochemical stain, we will see antibody bind to odontogenic amyloblast-associated protein, confirming that this protein is in fact odontogenic amyloid, as in developing tooth germs. Central odontogenic fibroma associated with central joint cell. So we have ossifying variant, granular cell, central fibroma, which have amyloid, and central deposition. Central odontogenic fibroma associated with central giant cell granuloma. In some cases, we see in histology not admixed. They are arranged in juxtaposed yet separated dimorphic pattern. The two pattern. Let's saw these slides. Odontogenic fibroma. We see calcification. We see giant cell reaction, which have, in case of cancer, a giant cell, 3 types: foreign body, the nucleus appear scattered; infection, horseshoe, nucleus will appear like horseshoe in case of infection. In case of a tumor, we will see them as pleomorphism. So we will see giant cell reaction inside the fibroma with epithelium. Not admixed. Rather, they are arranged in juxtaposed yet separated dimorphic pattern. We will see as dimorphic pattern. We'll see another slide. Here, there is giant cell reaction, as we will see, not admixed with another cells, and form as separate dimorphic pattern show two tissues. Odontogenic fibroma. You see the classifications. We see the odontogenic fibroma, which is squamous non-keratinized. We see here calcifications. Also, we see here calcifications. Here, giant cells. Odontogenic fibroma of the maxilla. This is from maxilla. We will see stroma, fibrocellular stroma, strands of epithelial island composed of peripheral arranged tall columnar cells, peripheral tall columnar cells. This is in low power. This about amyloid central deposition of white hyalinated globules adjacent to epithelium. We will see epithelium. Linear strands shows prominent cytoplasmic eosinophilia. This in A and B. We will show cytoplasmic eosinophilia, which is mean a cytoplasm with the pink color. In C slide, we see congruent stain for amyloid. This is stain for amyloid. As see, it is red apple in color. So demonstrate green by birefringence. And immuno in D and other slide is this immune stain for hyalinization of amyloid. Odontogenic fibroma with giant cells. This is giant cell appear not mixed with epithelium, show bimorphic pattern. This is show fibroosseous pattern. Densely pink to purple calcifications, so clear the calcifications, but the arrow show the epithelium in bone trabecula. And C we will see. In C slide we will see the immune stain. Immune stain either positive stains, which will be positive for cytokeratinase. Differential diagnosis: ameloblastix fibroma. Ameloblastix fibroma composed of odontogenic epithelial components, strands, cords, and islands, except peripheral palisading. Okay, what is meaning by palisading? Palisading only like this. Palisading appearance. Arrangement of tumor: a nuclei-like packet fencing. Pseudo-palisading has necrosis in center and left behind variable nuclei look parallel to each other by default, seen in glioblastoma. We does not have pseudo-palisading, we have palisading white trabecula separated by connective tissue. Seeing carcinoid, hepatocellular carcinoma, Merkel cell tumor, Gray-Loss cell, a tumor. This is palisading appearance. Wooden stacks or iron railings fixed in the ground, forming an enclosure. Also, see in ameloblastix fibroma. This is differentiated from oral fibroma. Primitive appearing stroma that is delicate and lobular in appearance. Desmoplastic fibroma, another differential diagnosis, was vesicles of variably SMA positive, smooth muscle positive immune stain, which stain myofibroblasts. Consider desmoid tumor of bone. This is just only for bone. So you can see the bone, if this bone is the tooth, so we can consider it in the oral cavity. Hyperplastic dental follicles with odontogenic fibroma like islands radiographically enlarged follicle surrounding impacted tooth. Collections of odontogenic islands like the dispersed nature of odontogenic fibroma. Odontogenic myxoma, spindled or satellite cells with eosinophilic cytoplasm. Eosinophilic cytoplasm means cytoplasm appear as pink in color. Set in myxoid matrix. Odontogenic myxoma have myxoid matrix, binucleated or heart-shaped cells. Mitosis and minimal atopia can be seen. Odontogenic myxoma. Odontogenic myxoma. So we say that satellite or spindle cells, eosinophilic cytoplasm, binucleated, heart-shaped cells, mitosis, minimal atopia. Abundant collagen is present. If it is present, the term myxofibroma or fibromyxoma. Showing scattered epithelial restes can also be seen. Let us see. So clear. High-power photomicrography showing closely arranged satellite-shaped cells with the intermingled fibral or fibular process in hemangious mucoid ground substance. So this is important lecture. We can download it. You can download it, not worry. Sclerosing odontogenic carcinoma. This is carcinoma. Of course, we will see the polymorphism. They vary from the benign cytology, aggressive pattern of infiltration, single file, thin cords, nests or strands of epithelium and densely sclerotic stroma. Epithelium or stroma dominate in different areas. Epithelial stroma. Epithelium can be seen in immunohistochemistry such as cytokeratin. Cytologically, individual epithelial cells are bland and uncommon mitosis, nothing mitosis, cytoplasm speculation partially clearing. Despite the bland cytological appearance, there is invasion. Because it is malignant, we also see invasion to the smooth skeletal muscle and perineural invasion. Perineural invasion. This is the nerve. This is nerve and tumor cells do invasion to the nerve. This is named by perineural invasion since they are malignant. Sclerosing odontogenic carcinoma. Sclerosing odontogenic carcinoma. so clear and closely not seen, but it is a primary cancer of jaws. As we can see, single file thin cords, nested and strands of epithelium, densely sclerotic stroma. Epithelium or stroma, different areas demonstrate different areas. Epithelium might be compressed so as to be seen just only by immunochemistry, cytology, and common mitosis. Cytoplasm contains vacuole. As we have seen, the epithelium, the stroma, and the cytoplasm which contain vacuoles. As we see with irritation, that what differential diagnosis for central fibroma. For peripheral fibroma, we will see irritation fibroma. Peripheral giant cell granuloma by gene granuloma. Irritation fibroma, nodular lesion from the dermal due to dermal proliferation of collagen bundles. Response to local irritation like itching. Peripheral giant cell granuloma, proliferation of multinucleated giant cell lump, oval mononuclear cells, and hemorrhage. Has similar appearance salt aneurysmal bone cyst. This is not important. By gene granuloma, we see it, or also named bilobular capillary hemangioma, common in pregnant. We see it in other slide. There is some question. Mandibular mass that is radiolucent by plain radiography, characterized by strands or nests of inactive appearing odontogenic epithelium with or without calcifications. Which of the following best diagnosis? We have plain radiograph in mandible for mandibular mass. Have strands or nests of inactive epithelium without calcification. Which we choose? We'll choose central odontogenic fibroma.